based eye care setting. I work a lot with our retina specialists, and ultimately, um, issues with the uvea kind of shake out as retina issues. The uveal tract, which is essentially what gets inflamed in iritis or uveitis, and we kind of use those terms interchangeably. Uveitis is inflammation of the uveal tract. Iritis specifically is inflammation to the iris, and the uveal tract is made up of three primary structures. The iris, which is the colored portion of the eye that you all see, it changes the aperture of the eye. The ciliary body, which is essentially a muscle, which does two primary functions. One function is to change the shape of the lens, accommodation, and the other function is to create aqueous humor, the fluid that fills the front chamber of the eye. And the third component of the uveal tract is the choroid. Choroid is a highly vascularized network of blood vessels beneath the sclera, which provides the support for the deeper layers of the retina. Inflammation in the eye is a very common association with systemic disease, primarily because the eye is a very vascular organ, and the structures you talked about are incredibly vascular structures. So Alec did a nice job in putting these slides together for me. This is actually the first time I've seen them, so bear with me as we go through it. Uveitis/iritis is something that I encounter frequently. Alec was saying it's always kind of nice to know how frequently is frequent. And I would say for sure every week and potentially more days than not. There's probably a fair assessment of that. In fact, today I had a follow-up on a patient with uveitis. If I were to break down uveitis, we're going to go through a classification of iritis here in a bit, but if I were to break down the types of uveitis I see, the primary form of uveitis is traumatic. People have an injury to the eye, just due to the structure of the eye and the motion of the organs, the structures through the eye in a traumatic event. The iris, the front muscle of the eye, oftentimes gets inflamed. And that inflammation is called iritis. In fact, Alec had a trauma to his eye as a young person, playing in one of the trampoline parks, dodgeball, ball to the eye gets compressed, the structure of the eye are forced posteriorly, then rush anteriorly, and the iris gets inflamed. So probably the most common form of iritis I see is traumatic. It's probably second form of iritis we see most commonly is simply idiopathic. We don't have an explanation as to why the inflammation occurs inside the eye. And the third most common form of iritis that I see is associated with some form of systemic disease and or autoimmune disorder. And the fourth, by far, way down the line is infectious uveitis. So let's just talk through a little bit then about how we classify iritis. When you're, I don't know how much experience you guys have had or understand the instrumentation by which we evaluate the eye, but the primary microscope we use is called a slit lamp. And most of the structures of the eye are transparent. And the transparent structures allow you to see the non-transparent structures which line the inside of the eye called the retina. So those structures are cornea, aqueous humor, fills the front chamber of the eye, the natural lens of the eye, and then the vitreous. And what a slit lamp does is allow for an angled beam of light to be transferred to the eye, allowing us to assess the structures. And the cornea itself is made up of 5 structures. The aqueous humor is essentially fluid. The lens is essentially an onion, which is multiple different layers, which you can assess the layers as the light travels through it on an angle. And the vitreous, although originally is very solid, clear, transparent fluid, over time it becomes more opacified as the aging process takes place. What we're looking for in iritis specifically is inflammation, primarily in the anterior chamber of the eye. You can see these diagrams here on the right-hand side. The space that exists between the cornea and essentially to the front of the lens is called the anterior chamber. To evaluate the anterior chamber, you put the slit of light through the structure, and you're looking for individual inflammatory cells. Cells which are leaked out of the iris tissue into the fluid in front of the eye. Because there's a convection current in the eye where the actual eyeball itself is warmer than the air outside, the fluid tends to move up in front of the cornea and down as it comes towards the lens. There's a convection. And what you'll see is these microscopic cells, individual white blood cells, floating through the eye. There's another clinical observation to make, and that is of flare, where cells are essentially the inflammatory cells, white blood cells are moving through the eye, and flare is the sort of secretion by which those cells are transmitted through the iris. So in a very complicated case, you grade inflammation cells and you grade inflammation flare on a scale of 1 to 4. So you could have 3 plus cells and 4 plus flare, depending on the type of inflammation you see. As I was saying, that the cells kind of move in a convection through the eye based on the temperature. The cells themselves can deposit on the back surface of your cornea. And we'll probably get into that a bit more later, but a deposit of an inflammatory cell on the back surface of the cornea is called a keratotic precipitate. So oftentimes when you first look at these people, you'll see the cells inside the eye, but if a condition goes untreated, those collection of cells ultimately stick to the backside of the cornea, creating a precipitate, a little white collection of inflammatory cells on the back of the cornea. There are different types of precipitates depending on the cause of the inflammation. Infectious causes generally create larger white blood cells that are more sticky with each other, and they create a keratotic precipitate that looks like a granuloma. We call it kind of a mutton fat KP, or a mutton fat keratotic precipitate. Inflammatory processes that usually come about due to autoimmune disorders, non-infectious issues, generally form fine keratotic precipitates, or just much less dense. And those are helpful in making diagnoses or taking a road one way versus the other in terms of, is this an infectious problem, or is this actually an autoimmune disorder, or is it, none of the above. So primarily, you're evaluating the anterior chamber. I would say 80% of the cases of iritis or uveitis that I see are anterior in nature. If inflammation starts to get further back in the eye, the consequences to the overall health of the eye generally increase significantly. The second form of uveitis, of which there are 4, is called intermediate uveitis. That's where the retina becomes involved, very anterior in the front of the eye. The most common reason, I think there's slides about this later for that, is multiple sclerosis. So if you see a collection of cells somewhat in the anterior but more